Good evening and welcome to our live call-in show. We bring from Opelousas and Heart and Vascular Institute as well as Cardiovascular Institute of the South. Tonight's topic here is carotid disease and all you need to know about what is carotid disease and what are the treatment options. And I'd like to start off by introducing my regular partners here. Regulars on the show, Dr. Clay Hammett, who's an interventional cardiologist in Opelousas, and Dr. Rob Minuit, who's an interventional cardiologist as well. Both of them practice in Opelousas along with me. I want to start off the show by blurting out some statistics about carotid disease. And the main thing we are concerned about as we are talking about carotid disease is the incidence of stroke. So we go ahead and talk about some of the statistics about stroke. Bear with me about these. About 145 to 150,000 people experience death secondary to stroke every year in this country. And if you take the incidence of strokes, somewhere about 790,000 people have strokes in a year, out of which about 600,000 are new strokes, and the rest of them will be repeat strokes. If you take it in a timeline perspective, roughly every 40 seconds, a person in this country is experiencing a stroke. And about 3/4 of the strokes are experienced by people under the age of 65, and the risk of stroke doubles in every decade after the age of 55. And also the risk of stroke is twice as much in people. Ischemic stroke, we'll go into discussion of different types of strokes shortly, but the risk of ischemic stroke is in smokers is double as much as a person who's a non-smoker. And also the risk of death as a result of a stroke is far significant in African American patients than our Caucasian patients. And blood pressure or hypertension or high blood pressure is the #1 cause of strokes in this country. So with that statistics, we'll go on into discussion about what are the different types of strokes and why are they caused and why are we talking about carotid disease when we talk about strokes. So I'll go ahead and start this discussion by posing a question to Dr. Hammett. So most people know what a stroke is, and just touch upon a stroke and elaborate what are the different types of strokes.
Well, a stroke is a simpler way to put it is a heart attack of the brain or a brain infarct. It's where part of the brain is not getting enough blood supply to give it enough oxygen, and damage is done due to the lack of oxygen and nutrients to that small or large part of the brain, depending on how big the area of stroke is. Multiple different kinds of strokes. First of all, there's hemorrhagic or bleeding type of strokes, where there is an actual break in the blood vessel, where there is blood that gets in between either the skull and the brain itself, or within the tissue of the brain. And then there's the non-hemorrhagic stroke, which is the ischemic stroke that Dr. Verena was talking about just a second ago, where there is a blockage of some sort. Then those can be broken down into whether there is a thrombus or embolic stroke, where something comes from lower in the carotid or from the heart and breaks off and rolls upstream and lodges into a blood vessel, to where it then creates the blood flow to stop to that area of the brain. Or a thrombus or a plaque gets large enough and builds up to it and impedes the flow to an area of the heart that causes the blood to stop flowing there also. So it can be broken down many different ways, but that's somewhat the basics.
Now that we have started off talking about stroke as the biggest, I guess, end point of having carotid disease, and I'll go on and ask Dr. Minuit about, as cardiologists, why should we be concerned about carotid disease when historically it has been considered a surgical disease? Where do we come in as clinicians, both as internists, in our case, cardiologists? Why should we be caring about carotid disease and educating our patients about that?
Well, first off, carotid disease is an extension of vascular disease that's not limited to the heart. Primarily, cardiologists dealt with heart-related issues, but blockages as a whole can originate in the heart, the legs, the neck arteries, or in the brain arteries. And so it's a much larger problem that encompasses blood vessel problems. And as we were saying earlier, about 20% of strokes that occur, 80% of strokes that occur are related to blood flow problems. Other 20% are bleeding. From our standpoint, and the way we treat and work up patients, just as, like I said, we have blockages in the heart arteries that cause heart attacks, you can have blockages that can cause lack of blood flow to the brain. It's very important from our standpoint because the treatment is very similar to how you would treat coronary disease. When you have carotid artery disease or blockage in the neck arteries, just like you would have in the heart, you think about this disease as like a blister inside the blood vessel. The material that's inside this blockage, if that blister pops, so to speak, and most people can relate to having blisters, before. Some are thick and some are thin, the covering, and they can be very friable and break. The thing is that if one of these blisters, so to speak, in the blood vessels in the neck or in the head ruptures, it reacts with the blood very violently and causes clots to form. If it's large enough, it can cause complete cessation of blood flow, and this is where a stroke occurs. It's like Dr. Verena said, it's a very high incidence in this country, and it's actually the third leading cause of death, only behind heart disease, which is number one, and cancer, which is second.
So that's a great summation. I mean, if you look at the, as we talked about, it is the third leading cause of death, and in terms of the cost of a stroke, in terms of a dollar cost for the healthcare, it's probably larger with reference to not only the incidence. Once a stroke has happened, the recuperation of the patient tends to be a lot longer than in patient with heart attacks that we care about, and we more so than we do about strokes. So the overburdening cost of stroke is far more significant than it seems than for cardiovascular disease. So that is one of the reasons. So talking about carotid disease, we'll try and talk about some of the risk factors for carotid disease today before we go on into showing you some simple CT pictures or CT angiograms of carotid areas, and then talk about the diagnostic methods and treatment options. As all of us know, the risk factors for carotid disease is essentially the same as any other cardiovascular disease. You start with high blood pressure, diabetes, high cholesterol, smoking, and these are the main, and lack of exercise and sedentariness and improper diet. These are the ones that we keep on pounding as cardiologists day in and day out. And patients come into our office with concerns about either family member having heart problems or them individually having heart problems. But being that carotid disease is predominantly a silent disease until the onset of a stroke or a mini stroke or a TIA, as we call it, which means basically a patient will have a stroke or stroke-like features with blurring of vision or slurring of speech or numbness in a certain portion of the face or body or difficult to think clearly. And these are the types of features. And if they're reversible within 24 hours, they're called TIAs. And whereas if they're permanent, all of us know they're called strokes, and they're left with some degree of permanent disability that the patient will have to work through. When patients walk into our clinic, Dr. Hammett, how should we start off leading towards, when do you start suspecting a patient has a higher incidence of carotid disease with all the above risk factors we are talking about? If they had all those risk factors and they walk in with a heart problem, when do you start really being concerned about carotid disease, and how do you go about starting off the investigations?
Well, to reiterate, or maybe even be a little redundant from what y'all have both talked about, the risk factors are the obvious place to start. Again, we can't say this enough. The diabetic, the smoker, the strong family history, the patient with high cholesterol, the obese sedentary patient. So that right there just grabs your attention and says it's screaming, check me. We need to know what's going on. The other issue is that if they have already had a vascular event or a diagnosis of some type of vascular disease, a blockage in the heart arteries, a blockage in the leg arteries, blockage in the kidney artery, etc., then they're prone to have blockage in the carotid arteries also, because all that runs together, just as Dr. Menuet was saying. So right there, those patients just kind of grab you and say, we're needing a workup. The other physical exam parts of that would be, as we do, there's an entity called a bruit. It's when the physician puts the stethoscope on the neck and actually listens to the carotid artery. It's somewhat of a murmur, and it basically is a noise that's heard through the artery, transmitted to the stethoscope, that kind of clues us in whether there may be a blockage there or not. By all means, that's not diagnostic, and certainly can't be graded as to whether it's a bad blockage or a mild blockage, and it may not even be present sometimes. But that sound is, if you have a water hose and water's flowing through the water hose, and the water hose is straight, it really doesn't, you really can't hear much water flowing through that. But as you bend it and kink it and make a narrow portion of that water hose as the water goes through there, then it starts to make a more of a hissing, high-pitched sound. And that's basically what is happening when we hear the bruit in the carotid artery. So that's just some of the physical exam perspectives. And then we get into testing, which we'll, I'm sure, elaborate more on, but the ultrasound of the carotid arteries, which it's similar to the echocardiogram. It's just an ultrasound where we actually visualize and measure the flow of blood within that artery to tell if there's a high velocity or a blockage there too. So and plenty more we can talk about.
Sure. I think certainly, as you said, it's not uncommon for patients to walk in and actually describe once in a while that when they sleep and they have their ears to the pillow, they can hear like a little bird chirping in their ear, or a squishing noise which kind of keeps them awake. And we've heard this when you talk to them. You're like, doc, I can't sleep well. Why do you? And then you go a little more into detail. They talk about this chirping noise or a little hissing noise in their ears, which should raise our concern that they're really actually screaming aloud to check. And it's a since carotid arteries are so large and so close to the surface in your neck, simply putting a stethoscope on it, you can hear a very clear noise that, and that should, of course, raise our concern and go further into investigations. And on that token, I want to ask Dr. Menuet about what other investigations do we have once we start with an ultrasound, and when should we be worried about doing more sophisticated tests such as CTs or other things? But what are the different grades of carotid blockages? If you can just shed a light for the audience about the ultrasound as well as the other modalities.
Yeah, basically, ultrasound is usually what we start off with. It's a simple procedure. It's non-invasive, painless, and basically just how ultrasounds are performed on pregnant women to look at the fetus. It's very almost exact same type of technology is used. And basically, like Dr. Hammett described, we're looking at basically the flow through the blood vessel and measuring how fast it's going